name is Jichuan Wang. I'm not a medical doctor, a PhD, but I have been working in the public health field for over 20 years. And in the past 8 years, I've been heavily involved in pediatric studies. As I know, in the National Children's Medical Center, Washington, D.C., there's a huge amount of data, information from medical records, clinical trials, and surveys, but most of the investigators still use traditional statistics methods for their data analysis, such as t-test, chi-square, ANOVA, regression, logistical regression. That's fine, but those methods have some limitations. And in recent years, lots of advanced screening methods have been developed, can be applied for all different kinds of studies, including pediatric studies. Today, I'm going to briefly introduce one of these new methods for pediatric study. So the title is Latent Profile Analysis on Symptom Clusters in Pediatric Studies. So latent profile or latent class, that means a subpopulation, a group of people that is a priori unknown. You don't know how many groups or subpopulations in your sample or in your target population with respect to a set of outcome measures. So through the data analysis, you will find out whether there's a heterogeneous in your population. If yes, how many groups? 2, 3, 4, or more. You will identify the optimal number of those groups. Once you identify these subpopulations or groups, you will see what make these groups distinctive. So the outcome measures are supposed to be homogeneous within a group, but heterogeneous cross groups. So this is the basic idea of this study. If we have categorical outcomes, this will be latent cluster analysis. With the continuous outcome variables, that's latent profile analysis. So in the pediatric studies, symptom study is very important. There are different terminologies in regard to symptoms. So first, you may say, thank you. You can refer symptom cluster as, okay, thank you. Symptom cluster as a group of symptoms that occur simultaneously. Then you're talking about a group of symptoms. That's one way to understand the symptom clusters. But now I'm talking about the different clusters. I'm talking about a group of individuals sharing similar symptoms. So this is different perspective. So when we say symptom clusters, in my study, I mean a group of people sharing similar symptoms. I'll use the example of using the real data from our hospital, from the promised measures of 4 symptoms: depression, anxiety, pain, and fatigue in children patients with cancer, to demonstrate these methods. So latent profile analysis and the extension of these methods to longitudinal study, longitudinal data will be latent transition analysis. That means you have a latent class classified as time 1, time 2, time 3, and the latent status, the group status change over time, then there's a transition. For example, you have, say, a membership at time 1, the severe symptoms, and time 2, the symptom class membership changes. It could be high, severe, become less severe, and remain less severe. So this status change over time. So with this longitudinal data, this method becomes latent transition analysis. So I have already briefly explained this difference. So when we're talking about a group of symptoms, that's called variable-centered. We're talking about grouping variables. We're talking about a group of individuals, that's person-centered. So the analytical approach associated with person-centered analysis is called mixture modeling. Variable-centered, I will tell you what kind of analytical approach belongs to this variable-centered approach. The symptom class can be clinically determined before empirical studies. Data can determine what kind of symptoms could occur for patient, what kind of patient they can define. So those group of symptoms should be observed, dissected together. That's variable centered, but it's predetermined. For when the symptom clusters are not predetermined, you don't know what kind of symptom will come together. But after you get the data, you can explore this kind of symptoms using exploratory factor analysis, principal component analysis, confirming factor analysis. Those are all called measurement models. Use this measurement model is kind of data reduction to group variables. Okay, but today I'm not going to talk about this variable-centered, but person-centered. Traditionally, classical approach is clustering analysis. Group individuals based on a set of outcome measures, basically continuous measures or dichotomous measures. But this kind of approach is kind of arbitrary. There's no model test. You get a group of people, but there's no statistical test whether this model fits the data. So it's fine, but not very good. A better approach is mixture models. Latent cluster, latent profile with longitudinal data is latent transition, and also group mixture modeling. Today I'm going to talk to latent profile and latent transition model. There are several advantages of using these mixture modeling approaches. Number one, it's not arbitrary. You have to do model test to tell where this model fits data, and also all different kind of outcome measures you can use. Continuous, categorical, nominal, censored, count data, or combinations of all these different type of data can be used. Now I'm going to use an example from a study in our hospital. They use children's version of PROMIS measure. There are 4 symptoms measures: anxiety, depression, pain, and fatigue. Each scale has multiple items. The first 3 has 8 items. The last one has 10 items. A total of 98 patients with this age were recruited from 2 sites. 3 time points. Time 1 is the start of the cycle of the chemo. Time 2 is midway through. Time 3 is after blood cell count recovery from following the cycle of chemotherapy. First, I conducted LPA at each time point, time 1, time 2, time 3, and then extend this latent profile analysis to longitudinal data. That means time 1, time 3 all together. And then test, once the latent groups or profiles are identified, or test the external validity and see whether this membership is associated with appropriately, associated with some external criteria measures. And then there's a baseline single item legacy fatigue measure was used to predict the transition of latent profiles. And we found that single legacy fatigue measure is very useful, can be used as a biomarker. If at the baseline, that measure give you the dichotomous, yes, fatigue versus otherwise, it's very likely you will find that patient will have difficult time through the chemotherapy, will experience kind of a severe symptom transition. Let me show you this figure first. So the red lines are at each time point, 2 profiles were identified. Severe symptoms versus less severe symptoms at each time. Time 1, time 3, time 2, time 3. The red line, the solid line is time 1. Dotted, the dashed line is time 2. Dotted is time 3. The red curves, red lines are problematic groups. The blue ones are less severe groups. So patients were classified into 2 groups. It's not arbitrarily classified. It's a model identified in terms of anxiety, depression, pain, and fatigue. So these 4 outcome measures together. This is the score, average score of these 4 outcome measures. So in this profile 1, on average, the 4 outcome measures, its level is much lower. This is profile 2, is more severe group. So every symptom measures much higher. But time 2, time 1 are almost the same, no significant difference. No significant difference. Time 3, the level is lower. So when we compare the latent profiles over time, the prevalence level of profile 2, so the percentage looks like it's going up. So about 52% of the patient were in the more severe group at time 3. That kind of impression is like the symptom level goes up because more people are classified in this group. But actually, average level of the symptom measures are lower. So in order to have a better comparison, we need to standardize it. So every group should have the same level, the same average measures of all these outcomes. Then we'll compare the percentage. That will be more meaningful. So this is unstandardized prevalence level. So time 3 has higher percentage. When we standardize it, standardizing means we run that latent translation model again, but with restrictions. Put equality restrictions on the mean value and the variance of each latent profiles over time. So then the time 1, time 3, time 2, time 3, each latent group or latent profile has the same level, same variance. And then we compare the percentage of people in each group. So in that higher in the profile 2, and that means the more severe group, at time 2 or time 3, percentage drop down, significantly lower compared with time 1 and time 2. That indicates the patient symptom actually reduced, the level of symptom reduced after the finish of the chemotherapy. So instead of increase, actually it's decreased. So this is $29 versus 44, 46. So this is time 3. It's after finishing the chemotherapy. Then external validity test is to check the relationship between the latent profile membership and other 3 promise measures, which are function measures. These are 2 profiles. It's time 1, 3 functions, peer relationship, upper extremity, mobility. So profile 1 has a higher average score. Profile 2 has a lower. Profile 2, that means more problem group. Their function score is lower. That's meaningful. Discussion. Children with cancer can be classified into 2 latent profiles with respect to the promised symptom measures. Less severe versus severe symptom profiles. Time 2 and time 1, time 2, that this prevalence level remains almost unchanged, pretty much the same. But prevalence prevalence level of profile 2 significantly declined. That indicates improvement of health status of the therapy. And this improvement just occurred after time 2. No. This is a validity check.时代的transition，你check。Looks like I missed one table. This is a transition information. Because there are 2 latent profiles at each time point, so there might be a possible 8 different transitions. So high, 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 low, 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 high, low, low, blah, blah, blah. All possible 8 transitions. The most likely transition pattern is there are 2. Start low and remain low. This is about 45%. And then start high, remain high. It's about 25%. And this baseline single item negative fatigue measure. That's orange measure that on 5-point scales, and then we call it as dichotomies. That means yes, you feel fatigue all the time. Versus otherwise, this baseline indicator looks like can serve as a biomarker. So if this is a yes, they are less likely to experience a low transition. But the odds ratio is 9.25, meaning for experiencing high and high transition. Once they have that measure positive at baseline, very likely they will have a symptom, severe symptom through the process, even after therapy, controlling for social demographics.
You have 5-minute affinity, right? I think it's okay.
Yep, that's briefly, that's my presentation. Any question?
A quick question for you that's a little bit out of this purview, but just out of curiosity. We're seeing more and more that symptom profiles in various disease states are being taken from search engines like Google. On a broader scale, do you see that as a possibility for things like cancer treatment and chemotherapy?
Of course. This methodology can be applied in all different areas. So long you have measures, you have reliable and valid outcome measures, then you can apply these approaches. Given the sample size is not too small.
Thank you, Dr. Wang.